Good afternoon, everyone. Welcome to this AWARE webinar this afternoon on understanding and discussing personality difficulties. My name is Dr. Susan Brannick. I'm a clinical psychologist and clinical director here at AWARE, and I'm joined by Dr. Paul Matthews, who I will introduce more formally in just a moment. So we'll give it a minute or so just to allow people to arrive in. So get settled, maybe get yourself a cup of tea, and we'll get going very shortly. So welcome again to those joining. My name is Dr. Susan Brannick. I'm a clinical psychologist and clinical director here at AWARE. You're all very welcome to our webinar this afternoon, which is on understanding and discussing personality difficulties. So just a brief note maybe on our webinars on AWARE before we get started. So for those of you who are unfamiliar, we do these webinars on the second Wednesday of every month, and they range over a whole range of topics of depression, anxiety, and related mental health conditions. You can find the ones we've done already on YouTube are also on our aware.ie site. On that site, you'll also find more information about our education, information, and our support services for people living with depression, bipolar, and anxiety. So this afternoon, as I said, we're going to be discussing personality difficulties. There is a capacity to ask questions if you're joining us live, so please do ask any questions that come up during our conversation. We'll do our best to get to as many questions as we can. As you know, we can't answer specific kind of personal queries, but we'll do our best to kind of talk about general themes and answer your question where possible. I would suggest maybe if you're left with any questions or if anything's resonated after this webinar, maybe talking to your own mental health professional, linking in with support system or GP, so whoever's in your life that's supportive and helpful at the moment. And what we'll do as well is link to some resources as we come to a close this afternoon. So maybe starting with welcoming Paul. Paul, thank you very much for joining us this afternoon. Paul is a consultant psychiatrist at the Mater with specialist interest in personality disorder. Welcome, Paul.
Thanks for having me, Susan.
Yeah, my pleasure. Do you want to say a little bit about yourself maybe and what's kind of brought you into specializing or having an interest in this area maybe?
Sure. So yeah, like you say, I'm a liaison psychiatrist. That's what my job is day to day. Before I did that, I was a community psychiatrist. I used to work in County Kildare. Prior to that, I trained and worked in the UK. And while I was over there, I would have worked in a specialist personality disorder service. So I guess that's where my interest comes from originally. But obviously, as a psychiatrist, personality disorders are an area that's kind of very interesting anyway. I think it's an underserved area, and coming to Ireland, it's an even more underserved area than it was when I worked in the UK. And so being a psychiatrist, I'm part of the College of Psychiatrists of Ireland, and we have a special interest group there looking at personality disorders. And we're kind of very interested in research in the area, but also about raising awareness, which is partly why I'm here, but also trying to advocate for the development of services, particularly in the Republic of Ireland, where we do have an issue of lack of services.
Yeah, absolutely. So I guess maybe starting with thinking about, I suppose, what is a personality disorder? And I suppose I'm aware, even as we're talking, some of these terms are maybe controversial in some areas, and I guess there's different ways and means of kind of understanding personality difficulties. I guess we all have a personality style, don't we, which is developed from childhood, that probably involves thoughts, behaviors, feelings, maybe how we experience ourselves and others. But how would you kind of define it maybe for us?
Yeah, it's difficult because it's different from other mental disorders, personality disorder, in the sense that, yeah, like you say, we all have a personality, so that's not abnormal to have a personality. And personality, it's the ways that we think and feel and act, and it kind of, it's what we call a trait. So personality traits, they're there all the time. They might fluctuate in severity, but it's kind of a consistent thing. And it's different maybe from how you might think about states. So when I'm intoxicated, I behave in a certain way, but that's not how I am on a day-to-day basis. Maybe I've had a depressive episode. I might be very low in mood for a month or so, and then I kind of go back to my normal way of being, which is my personality traits. So we all have personality, and the way that's understood kind of academically and kind of academic psychology circles is often around what we call the big five. So you can often think about people's personality traits in terms of kind of, are you an extroverted person? Are you very outgoing? Are you very agreeable? You get on with people very well. That's one end of the spectrum. Are you very conscientious? You work very hard. Do you have a lot of openness to new experiences? And do you have a lot of neuroticism? So neuroticism tends to be sort of anxiety, that kind of thing. So that's how everyone's personality is thought of, and it tends to be what we call a normal distribution. So sort of like this: most of us are in the middle, some of us are at the extremes. And that's normal. That's how everyone is. And so when we think about personality disorders, we're really saying people who are at those extremes, does that cause difficulties? So lots of people are at the extremes, and that's just their personality. It doesn't cause them major problems in life. And when we think about personality disorders, the disorders bit of it is about saying, does this cause problems in and we often think about it in kind of different domains. In my sense of self, who I am, does it cause problems in achieving my goals? Does it cause problems in my ability to understand other people? Does it cause difficulties in my ability to have relationships with other people? And do those difficulties impact on me? So do they cause me distress? Do they cause problems in my ability to function day to day in my work, in my home life, in education? So it's really arbitrary. Because these things are a spectrum, but we kind of draw the line around that dysfunction. So is it causing problems in multiple areas of life? And that's where we think about the disorder side of things.
Yeah.
Does that make sense?
Yeah, no, it is. I guess I'm thinking about that, how that might translate for a person. So I suppose, as you say, there's probably a continuum, isn't there, of personality, and we all have a personality, but probably we all have personality styles as well. So you might have certain traits, and your way of kind of summarizing that is helpful. If you're in a certain kind of mind state, like maybe being inebriated, as you say, you might act differently, but that's not maybe your whole kind of daily kind of way of relating. So there might be healthy and unhealthy aspects of different personality styles, which maybe we'll talk a bit about. But as you say, there's a kind of a cutoff at disorder point. And that's probably similar to other mental health conditions, that it's saying, well, this is stopping me doing what I want to be doing. And I guess maybe what you're suggesting maybe is that fundamentally that's a kind of a challenges in relating to people, how you might relate to yourself and other
Yeah.
people.
I think
Yeah.
how you relate to yourself and how you relate to other people and how you understand yourself and how you understand other people is really where we're finding that, the dysfunction is kind of kicking in. And of course,
Yeah.
the problem with personality disorders as a way of speaking is that's really personal. You're saying me, the way I am as a person, my personality is in some way disordered, and that's a horrible thing to hear. And we don't really mean that. I think, we don't mean you're not a nice person. We just mean that there's ways that these kind of ways that you tend to act can cause difficulties. Maybe they're inflexible. Maybe maybe they're limited in kind of their range. But I think it's understandable why anybody would find that a difficult term to hear, and certainly things like complex emotional needs are commonly used as a kind of euphemism. We tend not to use them so much here in Ireland, largely because I think understanding of personality disorders is so poor, and awareness in general is not very good. So we were kind of reluctant to use different terms because we worry that we're barely getting awareness of personality disorder, so we don't want to use different terms. But if we were saying in England, the debate around the label would be much more alive. And in fact, the personality disorder service I worked in was called the Complex Needs Service. It wasn't called a personality disorder service. It dealt with people who had difficulties that you could call personality disorders, but that wasn't what it was called. You didn't have to buy into that model to use the service. You could use the service if your problems seem like the kind of problems that we could help. So I think it's important to know that there is a live debate there. A lot of people don't like the terminology. The current kind of diagnostic classification systems use those terms, but a lot of people disagree with them.
Yeah, it can be contentious, kind of similar to the service I worked in as well. It was complex needs, and I suppose there's different ways to kind of think about that. It can feel very personal. I suppose it's maybe kind of being mindful in our conversation today as well. Some of this language might resonate with people, so it may not with other people. And I guess it's just kind of thinking about what's helpful. And I suppose we had spoken a bit about that idea of we maybe come back to it more, but a label can be helpful in terms of the help that it can open up. Sometimes it's not helpful, sometimes it can be. It's kind of different for different people. But I suppose maybe that idea, yeah, that feeling may be quite personal. It's my personality that's the problem. Well, but I suppose as you're saying, maybe it might be ways of navigating the world that you needed to develop when you were younger, and all the other kind of influences into that piece of what might kind of develop into a personality that may not be so helpful currently. I don't know, would you say is that?
I think that's a nice way of thinking about it. I mean, personality disorders cover a very wide range, but often when we think about mental health services, the people that we would tend to see would tend to have difficulties more in the borderline or emotionally unstable personality disorder area. And certainly for people in that area, I mean, it's pretty clear that difficult early life experiences are really common, including, up to and including abuse. And, you develop ways of coping, particularly as a child, that, it's survival, isn't it? It's emotional survival. But as you grow older, some of those patterns are not as useful as an adult. They lead on to other difficulties. And I think understanding where these things come from is really helpful, because it helps, gives you some compassion for a start. But it also, I think it's helpful if you're the person with those difficulties to know, this is what I had to do to survive, and have that sense of, it's not that I'm a bad person. It's not that I'm not doing this on purpose. This is what's happened to me. This is how I've developed, and now I need to move forward. But but acknowledging, and like I say, having that compassion for yourself that I got to this point not through not through any fault of my own, and then it's about, well, okay, how can I move on now? How can I do things slightly differently that might make my life better?
Yeah.
As it's not true for all personality disorders. Some personality disorders have a very different presentation, and maybe don't have so much connection with early adverse experiences, but certainly the kind of people that I would see clinically.
Yeah. I guess that maybe comes to the impact again, doesn't it? So some people may not, as you said, might kind of be defined by psychiatry as kind of in that realm of disorder, but aren't maybe expressing difficulty themselves. So I suppose when you mentioned kind of EUPD there, that's the kind of impact again. So this is kind of really getting in the way of intimacy, connection, kind of day-to-day life in a sense. Things feel very difficult at times, maybe.
Yeah, and you touched on kind of two different areas there, I think, which is, one of them is well, where's the impact? So again, a lot of people we see in mental health services, they feel really distressed and upset about these difficulties, and that's why they're seeking help. Whereas other people, maybe the difficulties are more evident to those around them, and that's quite a common kind of difference. But also, I think the other thing you kind of touched on is that kind of spectrum question. And I think increasingly people become more aware that the personality difficulties are a spectrum. Some people have extreme personality traits that have only minor difficulties for them, all the way up to people who have extreme personality traits that cause massive difficulties. And actually acknowledging that there's a spectrum is quite helpful. So some people wouldn't meet the criteria for any kind of disorder. You have quite extreme personality traits, but they wouldn't meet the criteria for a disorder. But maybe you actually would benefit from some help with them. And that, I think, is where it's kind of nice to recognize the spectrum. So you don't have any diagnosable mental disorder, but actually this service would be helpful for you to make your life better. So that's, I think where the spectrum approach is quite useful.
And I guess maybe just thinking back to an earlier conversation, that idea that, and we'll talk about maybe, as you said, that kind of someone might be presenting for help with difficulties in their life, so that maybe you might kind of self-diagnose or might wonder about a diagnosis. And then I'm thinking about maybe EUPD or those kind of difficulties, and then maybe something like narcissism is something we tend to diagnose other people with. I say that slightly facetiously, but I guess that's, it tends to be something we see in other people potentially. So I guess that speaks a little bit to difficulties that may or may not be recognizable. But do you want to say maybe a bit about what EUPD is then, or how we define that?
So yeah, so EUPD is it's a funny term. You hear it's always referred to in terms of the letters rather than the term. So EUPD stands for emotional unstable personality disorder, and the more common worldwide label for that would be borderline personality disorder. So essentially, that particular term was coined in the ICD-10, which is the International Classification of Disease number 10, which came up with that term for borderline personality disorder, and it's taken off in Ireland and kind of the English-speaking well, not in the US, but sort of Ireland, the UK, places like that. It's really commonly used, whereas other places would still use the term borderline personality. And actually, the latest diagnostic systems have gone back to borderline personality, and there are problems with that as well. So emotional unstable personality disorder kind of does what it says on the tin. Its kind of primary presenting difficulties around unstable emotions. So people would have unstable or very kind of intense emotional changes, anger, this thing called chronic feelings of emptiness, which is very characteristic. But also there are lots of other difficulties that would tend to go with that. So relationship difficulties, fear of abandonment, very intense and unstable relationships, kind of self-destructive behaviors, maybe impulsivity, self-harm, suicidality is very common. Disturbed sense of self, so maybe your self-image of thinking who you are, even your sexuality, can be quite unsure about that. You can get what we call dissociative symptoms, where you can feel disconnected from your body or the world around you, and even kind of paranoid thoughts, or occasionally kind of brief psychotic symptoms, so hearing voices maybe. So it's quite a collection of lots of different symptoms that clinically seem to go together, and that would be the most common presentation I think we'd see in mental health services, because if you experience that, you're going to seek help for it. You're going to want to come and see a psychiatrist and say, these I'm having these real problems, can you help me with that? So and you might not know what it is, but you'll know there's a problem there, and you might think maybe you're depressed, you might think you have bipolar disorder, but you're going to see a problem. So that's why, although it's not the most common personality disorder, it's the most common, I think, reason for someone coming seeking help for a personality disorder.
Yeah, I guess it's going to have a big impact, isn't it, on kind of day-to-day life and functioning, as you say. And I guess as you were kind of mentioning earlier, there's kind of differences amongst the personality difficulties, but this might be more potentially related to earlier adverse childhood experiences. So that
So
idea that kind of complex trauma sort of diagnosis as well. And I guess that's where some of the conversations happen around this. So people are very kind of anti that term, aren't they, of EUPD, and see it very differently. And I suppose it's just helpful to note there's lots of different perspectives on it, maybe.
yeah, so we certainly know that people with borderline personality disorder are very likely to have had adverse early experiences, ranging from maybe neglect, physical abuse, up to childhood sexual abuse. And rates of childhood sexual abuse can be maybe as high as 70% in people with borderline personality. So not everybody with borderline personality has had childhood abuse and adverse experiences, from what we can tell from the research. And certainly not everyone who experiences childhood abuse goes on to develop borderline personality, but there's a very strong connection there. And I think that really goes with that idea of both attachment, how maybe your attachment to those early caregivers can be really disrupted by an abuse or neglect and so on, and then how that can kind of generalize to adulthood, where no wonder you're having difficulties with relationships if your early relationship patterns were like that. So yeah, it's very closely connected with, so complex PTSD as a diagnostic category is very related. And I think we may talk about other kind of things that can maybe look like personality disorders, but complex PTSD, I think they're so overlapping that it's not really necessarily meaningful to call them different disorders. So complex PTSD is essentially, you have PTSD, usually from complex childhood trauma, and you also have other difficulties that look like the difficulties of personality disorders around relationships, sense of self-worth, and so on. So a lot of people would think, particularly around borderline personality, of it as being a complex trauma condition, and it makes perfect sense. So certainly there's a real connection there. It's probably also true that there are some people maybe who are very emotionally sensitive by nature, and so they're probably very much more vulnerable to developing borderline personality. So there's a kind of experience and then sort of maybe genetic interaction going on there. So I think it's really about a question of perspective in that sense. Clearly there's a very strong trauma aspect to this, and I think it's about what lens you look at it through.
Yeah. And I guess even just thinking about what we're describing, I suppose it would understandably impact on mood as well. So you might kind of have these kind of experiences that can be very difficult personality wise or kind of relationship wise. That's going to then maybe, as we said, kind of cause challenges in relationships. So then that will impact on mood. So maybe you might also experience depression as part of that, or anxiety, or
Yeah, so we know that personality disorders in general, but borderline personality in particular, are very strongly comorbid with other mental disorders. So, and again, like you say, it's not a surprise. If I'm having these difficulties, I'm already more vulnerable to going on to develop. I already have those risk factors for developing other mental disorders. So, depression, anxiety disorders, substance misuse, eating disorders. You're all already predisposed towards developing those. And that's the important thing is. I think when you're working with people with personality disorders, it's really important not to label something as, say, depression when it's a part of the personality disorder, but at the same time, it's important not to miss depression and label those symptoms as being part of the personality disorder because the treatments are very different. So you have to be very careful.
And what would that look like for the person maybe who's kind of coming to you, kind of maybe describing some of these difficulties? What's the kind of options for help, or I guess not just their services, but also maybe how you might start supporting someone to kind of gain that reflective capacity, I suppose.
So I think the first stage really is around understanding somebody's story and making those links. And that's sort of, so the diagnosis, why do we make a diagnosis? Diagnosis is there to understand what's going on for you. It's there to maybe understand what's likely to happen, so prognosis, and it's there to guide treatment, both in terms of what's going to be useful and what's not going to be useful. And so I think the first stage is really understanding somebody's story and reaching a diagnosis. I think that's the first step. And then after that, it's around kind of signposting to treatment. And really, if we think about so if someone has a comorbid depression, then the treatment's the same. That you treat depression or anxiety disorders in the context of personality disorder like you treat them for anybody else. We know that having a personality disorder makes the treatment more difficult, but the treatment itself would be similar. But then you want to think about what difficulties are more attributable to personality disorder, and then what treatments are most appropriate for that. And really, I think personally, I'd be advocating for a sort of stepped care model. We talked about how actually personality difficulties are on a spectrum. I think the interventions need to be on a spectrum as well. So they might be as little as people with milder difficulties, just understanding what's going on for themselves. They might be more kind of skills based, and that's often what we would be looking to offer on a kind of first stage. So ways of managing emotions, ways of managing distress that maybe are different from what you've learned before. And then for people with more severe and enduring difficulties, the evidence base nowadays really favors sort of longer term psychological therapy. And that's how things I think have changed over time. So you talked a little bit earlier about people don't like the diagnosis of personality disorder. And it's not just theoretical. People have received personality disorder diagnoses and found themselves either given the wrong treatments or locked out of having treatment altogether. So there's a stigma there that's real. It's not that people are just feeling sensitive about it. They've seen it happen for themselves. So, and that was partly, I think, because historically people used to say personality disorders are untreatable, and so people should just be, sent off to cope by themselves. But now there's a really strong evidence base for psychological treatments for personality disorders. Dialectical behaviour therapy, DBT, is kind of really the one that's kind of the original one that was really demonstrated to be really effective, and that's what's usually available in Ireland, if anything's available. But there's lots of other psychological therapies with good evidence base, the MBT, mentalization-based treatment, and other therapies like schema therapy, cognitive analytic therapy, transference focused therapy. There's loads of psychological therapies, but the real kind of evidence would say that if you have a more severe difficulty, it's about consistency and kind of longer term treatment. So the best evidence-based ones, the DBT and the MBT, when they were originally developed, they were 18 months long. So that's and you do weekly individual session, weekly group session. That's intense therapy, but it's effective. And really, I think what's happened over time is people have started to say, well, actually, do we need to do quite so much of that? And have been kind of titrating it down to develop therapies that might go in at different levels depending on how severe your difficulties are.
It's interesting. I think DBT has really taken off in Ireland, hasn't it? Less so MBT. I'm not sure what that is. So DBT, as he says, dialectical behaviour therapy. It's very skills based. It's there's a fair bit of mindfulness in it, isn't there? And there's also kind of like
mindfulness is a core skill.
Yeah, So, and I guess that being the premise of how you then might be able to recognize what's happening and then regulate it, because you have to have that awareness, don't you, first before you can do anything. Mentalization based therapy, do you want to say just a line on what that is?
Yeah, so it's kind of funny. It came out of the of a more kind of psychodynamic therapy background, but it's not very psychodynamic in its actual practice. So it came out of London, and it's really around mentalization. So mentalization is the ability to identify, reflect on, understand mental states in yourself and in other people. And there's quite good evidence that certainly in borderline personality, people really struggle with that. So they have difficulties identifying why they're doing things themselves and why other people do things. And mentalization is really around kind of almost treating that like a muscle. You're helping people to work on that skill. And again, it's a longer term therapy, but it's really good evidence for the kind of effectiveness of that as a treatment. And actually, all of the psychological therapies really are based around borderline personality. So the evidence base is primarily for borderline personality. And it's interesting that the latest diagnostic system that's used in kind of the world outside of the US is the ICD-11, and that one's moved away from these sort of diagnoses. So personality disorders used to be sort of borderline personality, paranoid personality, antisocial personality, and empathic personality. All these kind of subtypes, and that's really moved away from that. But it kept borderline personality, and it kept it after some controversy, really because there's such an evidence base for treatment that people are saying we need this diagnosis because it's how we access treatment. And so the downside is that the evidence base for other patterns of personality difficulties is less good.
And I guess it's a bit circular, isn't it? Maybe going back to what you were saying, maybe if there's less of a people kind of coming for help with it, there's less of an appetite maybe to develop programs and research around it. I'm just seeing there's a few questions coming in, so thank you for asking those questions. We'll come to them maybe in a moment, but I just want to pick up on something that you had mentioned a little bit earlier, Paul, I guess, thinking about EUPD and this idea that maybe some people might be a little bit more predisposed to, I think the word used was maybe a bit more sensitive to emotion. I suppose it's a clunky bridge, but I wondered about maybe the link between neurodivergence and I guess that kind of comorbidity and overlap maybe in terms of, I guess, the things that people might be coming for help with and how you might kind of unpack that with them.
Yeah, so it's a complex area of interface. So it's complex for a few reasons. One of them is that I think there are symptoms of personality disorders that overlap with symptoms of neurodivergent conditions. So there are these, subtype like schizoid personality and anacastic personality with kind of very rigid thinking, kind of difficulties in making connections with other people and so on. Well, you can see the connection with autism there. And the historical research, these things haven't really ever been distinguished. So it may well be that actually one and the other is the same thing. It's not really been well kind of evidence. So you've got that kind of overlap in the diagnoses aren't even clearly different. Then you've got that question of vulnerability. So it's particularly something we would think about in women. If you've grown up with a neurodevelopmental disorder, autism, ADHD, you're probably more likely to have experienced things that might cause difficulties, might be risk factors for developing a personality disorder. So you've got, you might have been taken advantage of, you might grow up in a home where there are difficulties. So you've got that side of things as well. And then you've also got an overlap of symptoms, for instance, like emotional sensitivity can be seen in ADHD. And I talk about mindfulness, mentalization, sorry. Mentalization is theory of other people's minds. Well, theory of mind is a core deficit in autism. Now, I think they're slightly different deficits, but, conceptually they overlap. So you've got that side of things as well. And there is a view that maybe, again, particularly in women, maybe we're labeling people with borderline personality when they actually have autism. I think that's always, that's obviously true to some extent. There's always cases of misdiagnosis, and then you also have that question of comorbidity. So do you have both of those difficulties? So it's a real area, I think, of that we're still working through. There's not great evidence either way to know exactly what's going on, because, like I say, these things have been considered in silos, and it's only recently that people have been trying to say, well, okay, what proportion of people with borderline personality have autism? What proportion of people with autism have borderline personality? You know, it's an area I think that we're still really trying to come to terms with. Kind of from a practical level, it just means you need to keep an open mind, and when you're seeing somebody, you need to be just thinking not what's the one diagnosis I'm going to make here. It's like what's the overall pattern. And that does reflect a problem we do have at the moment, I think, in mental health services in Ireland, which is that autism, ADHD are not really part of the core of mental health services work. And there's some work on ADHD and very little work on autism. So people are sitting in this sort of no man's land. And that's a real problem, I think, that we haven't come to terms with and got to grips with. So it may be that you can get a diagnosis of borderline personality, but you can't get a diagnosis of autism. You have them both, but the services aren't there with the skills to make those diagnoses.
Yeah, they may not be as joined up. And I guess it's again coming back to what's going to be helpful for people. I'm just going to look at a couple of the questions here. I suppose thinking about there's one here actually. Maybe I will go to this one first. So thank you for this question. Are personalities fixed early in life or changeable later? I think we've touched on it a little bit. What's your view?
So personality, it seems to be something that kind of particularly arises when we're in childhood and starts to sort of develop and become more manifest in adolescence. And if you think about personality disorders, some of them really become obvious in like childhood, as in, you know, primary school, and other ones become more evident in kind of adolescence. But there's been a kind of a move as well towards thinking that actually personality is a bit more malleable than that. So historically, personality disorders had to be diagnosed, they had to be present in childhood or adolescent. And if they developed, those kind of patterns developed as an adult, that wasn't a personality disorder because it happened when you're an adult. Whereas, again, the diagnostic criteria have moved to this idea, well, actually, sometimes really catastrophic experiences in life can change our personality. And I suppose you might see that with complex PTSD. But it's also the case that we know, for instance, say borderline personality, by the time someone's about 50, I think only something like a quarter of people still meet the criteria. Doesn't mean they don't still have difficulties, but it shows how personality changes over time. It doesn't change massively, but there are drifts. What tends to happen over time is our personality tends to kind of round off, and some of the edges tend to come off as we get a bit older. Now, if you develop dementia, often your personality can coarsen again. But certainly as we get older, that there's a degree of mellowing, I think, in personality. So it's a slow changing thing rather than a not changing thing, if that makes sense.
Yeah. Okay. And I guess, yeah, as you said, amenable to maybe what's going on in the environment as well. There's a couple of questions here. Maybe there's one around how you might support someone with a personality disorder in the workplace. That's from someone in HR. So I guess kind of thinking about the more organizational context.
That's a tricky question, I think. Partly because I think personality disorder is very individual. Now, if someone's linked in with a mental health service, they might be very good people to work with. I think it's a general observation, not just for the HR position, but for anybody working with people with personality difficulties, is there's a real tendency to one of two responses. One of them is to want to help too much and then get really over involved and take kind of power and responsibility and control away from that person. And the other is to be very punitive and blaming and withdraw. And in mental health services, we see that. It's really common. And we really try and encourage everyone involved to sort of walk a middle ground. So people need to be given support, but they also need to be encouraged to have their own kind of take their own kind of responsibilities for their difficulties. So I think it's very difficult to say from an HR perspective, but really you want to be talking to the person. So how is this affecting you? How is it going to be helpful? And you want to be finding a way that you're working with them to identify reasonable adjustments to the workplace that allow them to function, but at the same time, not saying, you don't have to do anything. It's about people need to kind of have their own kind of autonomy and control, and you can't be just if you infantilize people, if you're just like, oh, you're sick, you can't do anything, then that's really unhelpful. We find in personality disorders that people really need to be empowered to develop their own kind of control and strength.
And I guess I'm not sure if you'd agree with this, but I suppose it maybe if you're in that position, maybe it's also helpful to reflect on your own personality style and what might be activated in you, or kind of bringing that reflective capacity, as you said, kind of getting that middle ground is really helpful. Not necessarily always easy, but something that takes a bit of practice and intention. Would you add anything in then to the, maybe kind of, there's a couple of questions here on similar question, but like from family members or partners, maybe specifically around neurodivergence and borderline PD. What
As in how to manage that kind of
I guess how a
interface.
family, how a family member or partner might support that person they care about in their life.
So yeah, I think again, it's about, there's a nice model from a philosopher called Hannah Pickard, which is called responsibility without responsibility without blame. Now I'm fond of it because she worked in the same service as me, so obviously I'm biased. But what's quite nice is it's about understanding where it's come from for people, and you're not blaming someone for the problems, the difficulties they've had, because often it's come from a really difficult place. But at the same time, holding them responsible for their actions. So it's walking, again, and it's very easy to say, just walk the middle line, but it's about finding that way of recognizing when people are having difficulties and suffering, but at the same time empowering them to make those changes. From a family member perspective, there's quite a nice program called Family Connections, which is run as part of the DBT programs in some parts of the country. Now it's not necessarily widely available, and it's often only available for people whose family members are in a DBT program. But if you go online on YouTube, there's a series of videos about that, and I have to look it up because I can never remember what it's called. It's called Open Your Mind Before You Open Your Mouth. So if you search for that and search for HSE, so there's an Irish specific version, that's really helpful about kind of understanding where things are coming from for people, and then finding ways of trying to help without trying to take control, because that's the kind of the line you're trying to walk. You're trying to help people, but you're not trying to take control away from them, because that will tend to make things worse.
Yeah. Thank you for that. So open your mind before you open your mouth. That's it. It is a mouthful. And that's on YouTube. And I suppose that might be specifically for supporting a loved one or trying to figure out what's going to be kind of a helpful approach. Is that? Yeah.
Yeah. So it's specifically designed for family members and friends and carers. Yeah.
Great. Hopefully that's answered a couple of the questions that have come in there about kind of supporting people. An interesting question here too about whether is there a strong correlation with personality disorders and addiction?
It's certainly the case that, think about it from first principles. If you're somebody who has difficulties managing your emotions, you're going to look for ways to help with that. And whether that is prescribed medications or whether that is illicit medications, alcohol, and so on, it's a strategy that you might choose. So it's not a surprise that people are more likely to develop substance misuse problems. And then, think about substance misuse in general, there are reasons why people develop substance misuse, and that this is one of the reasons why you might develop substance misuse. So there's definitely a correlation, yeah. And when we work with people with personality difficulties, we would normally try and target the substance misuse first, because it's for two reasons. One of them is it tends to make things worse, because often intoxication can really exacerbate those kind of emotional dysregulation and so on. And the other is that it's very hard to work on the skills that you might need if you're trying to numb emotions with medication or with substances. And I guess that comes to the thing we haven't talked about maybe, which is medication in the context of personality disorders, that they're very commonly used, but are they effective? I'm not so sure in the long run. So people will often be prescribed kind of sedating medication, and if you're kind of cutting yourself off from emotions, that's achieving something in the moment, but it's probably not great in the long run. And so we tend to discourage a medication as a long-term strategy.
I guess it's more, isn't it, in terms of the longer term psychological therapy. So that's kind of, I suppose, again, it's that phrase I used before, that kind of reflective capacity, and then maybe building skills as well. And the mentalization piece is really key. I don't think mentalization is probably a key part of every therapy, isn't it? And I think what maybe I heard a way to describe it, you know, this of trying to make sense of yourself or other people. It's maybe seeing yourself from the outside and seeing other people from the inside. And that can fluctuate, can't it, in periods of distress or in kind of heightened emotion. But that's so medication, as you say, might be helpful in certain instances, but I guess you really want to be able to sit with the emotion and then make choices around it and build those skills, as well as developing that kind of self-insight and awareness. And I guess I'm sort of making that point because, as you say, not necessarily a huge amount of services, but that doesn't mean that people can't do things to kind of make changes or kind of work with some of these difficulties. So just thinking about any other questions. Something came up there about, so thank you again for the questions coming in. As I said, we'll do our best to answer as many as we can. Someone had asked about avoidant personality disorder and what kind of treatments there might be around that.
So yeah, that's kind of interesting. So historically, personality disorders were often divided into three kind of groups: Group A, Group B, and Group C. And the Group A were things like paranoid personality disorder, which were the kind of more strange, people would say, you know, kind of, whereas Group B were more things like borderline personality, much more emotional dysregulation, and Group C are much more what you might call neurotic. So people with anxiety, people with dependent difficulties, people with maybe more kind of rigid obsessional thinking. And often the people in the last group, the Group C, are the ones you see more, they're very much more comorbid in people who
You're frozen a bit there, Paul.
have other mental disorders. So maybe, oh, sorry, can you hear me now?
Yeah, you might want to just repeat that bit. I think we might have missed it.
Sorry. So yeah, so those cluster C personality disorders, like the anxious avoidant personality, they're sort of they sort of slide in or grade into maybe more diagnosable anxiety disorders. So we know that a lot of people with anxious avoidant personality would have a full-blown anxiety disorder, maybe half of them, but half of them won't. So there's a real overlap, because anxious avoidant personality, by definition, it has anxiety in it. Often a lot of fears around kind of being judged by other people, that kind of thing. So a lot of the treatments are similar. So certainly psychological therapy would be similar. Things like CBT. People will sometimes use medication with a kind of anxiolytic component to it, like they would with anxiety disorders. So it's more like what you might do for anxiety disorders themselves. But I think it's also true that there's an argument, and I think there's a lot to go with it, that actually anxious avoidant personality is maybe at the milder end of the same difficulties you might see with borderline personality. So potentially, if it's really difficult for somebody and really kind of entrenched and isn't improving with other treatments, then maybe some of the same treatments you might use in borderline personality, so things like DBT, might be helpful. So some of those more skills-based treatments, if the kind of the classic anxiety treatments aren't working.
Okay, great.
And that's partly why the ICD-11 moved away from having these separate diagnoses and saying, actually, we think these things are all kind of interrelated, and some of what we're looking at is just a spectrum. So borderline personality is just more severe than patients with anxious avoidant personality, but they're kind of the same.
It's interesting, isn't it? As you say, there's a lot of overlap and a lot we don't know. And I suppose maybe it's more about what's difficult for the person in front of you, isn't it? And kind of there, as you say, so kind of some of the patterns around that. And maybe that ties into another question here, which is asking, is there a particular language we should be using around personality disorders? Are there common ways that they are referred to that we should be moving away from? What do you think to that?
I certainly think, so something you'll see in mental health services is PD. So that's really unhelpful. You know, it's bringing it down to the kind of like just two letters. It's not even it's not even giving it the full label. But I mean, it's really difficult, because I say there is that historical stigma that you can't move away from. It is there. But at the same time, things like complex emotional needs, sometimes they're a bit vague. You know, what does complex emotional needs? Because sometimes that refers to other things that, you know, particularly in maybe with children. So I think personality disorders is the imperfect term that we have, but it's about how you use it. And so, for instance, when we're developing maybe kind of recommendations and guidelines, you might talk about people whose difficulties might meet the criteria for personality disorder. So rather than people with personality disorders, or certainly not personality disorders, but people who have such and such difficulties. That's sometimes a nicer label. But at the same time, we need to be careful not to just get too euphemistic. This is the label. This is what it is. So you don't want to hide from it either. But I think, it's really about how you're using it. If you're using it in a respectful way, I personally think that's okay. Other people might not. But if you're using it in a disrespectful way, then it doesn't matter what label you're using. And we've seen that in the previous history with terms like mental retardation and then intellectual disability. If you're using it in a discriminatory way, it doesn't matter whether you reframe it. It carries the same discriminatory, stigmatizing meaning.
Yeah, absolutely. I think there's nothing worse than that PD label in mental health services. It's pejorative and stops thinking, doesn't it?
It's a shorthand to stop thinking. You're right. Yeah.
Stops any reflection. And I guess maybe just thinking about that, would you say even if you were to name even one or two myths about EUPD that it might be helpful even to debunk here, that might be commonplace?
So I guess one of the ones that I guess it isn't a myth about borderline personality, but is a myth in general, is people who self-harm or who are suicidal don't necessarily have personality disorders. Self-harm and suicidality is a highly complex, socially kind of positioned series of symptoms and expressions, and come from all kinds of different causes and reasons. So there's a real risk, I think, particularly with women again, if someone comes to an emergency department having self-harmed or feeling suicidal, to just say, well, they have a personality disorder. That's not the case. You need to unpack where this is coming from. And also, just because somebody has a personality disorder, it doesn't mean that their suicidal thoughts or self-harm are somehow less meaningful, need less attention. And that maybe comes to that kind of idea of manipulativeness that you sometimes hear. So this person is manipulative because they have a personality disorder. That's a really harmful myth, because usually what you're not seeing is someone being manipulative. You're seeing somebody who's using the only way they have of eliciting care and help that they've developed through usually difficult adverse experiences. And so they are care seeking in the only way they know how. To call that manipulative is I think not just pejorative. I think it's very unfair. And like you say, it stops thinking. Kind of other myths, I think maybe we touched on the question of it being something that you have for lifelong and doesn't get better. I say there's very good evidence that just without any treatment at all, people with particularly borderline personality, the symptoms improve over time. And then on top of that, with the evidence-based treatments we have now, there's lots of evidence that those treatments are very effective. So the whole untreatability myth is absolutely has to go out the window. Sometimes there are myths around risks to others, I think. So it is true that if you look at particularly, say, male prisoners, there's a disproportionate rate of antisocial personality, which is a particular kind of personality disorder characterized by maybe being more likely to cause harm to others. But that's just one subset of people. Most people with personality disorders, the risks, if any, are to themselves. So we really have to move away from that kind of being afraid of people with personality disorders. And I think we're afraid of two things as a society. We're afraid of harm to others, harm to themselves, and we're afraid of emotional expression. People really don't cope well with people being distressed. A lot of my work actually is around cancer, and a very common reason to be referred to me is because you've cried because someone told you got cancer. And that's fine, that's normal. But I think we're increasingly intolerant of emotional expression as a society, and afraid of it, and we want to pathologize it. But actually, it's fine to be upset and to cry, and to shout and scream sometimes. And we need to stop thinking that someone has to be dragged away and locked up in a psychiatric hospital because they've got upset. And I think that's a real myth that we have, that overt expressions of emotion have to be pathologized and locked away.
It's a really good point, isn't it? Certainly, yeah. When I worked in general hospital as well, the most common referral. This person is distressed around bad news. So I guess there's something about structural capacity to tolerate a strong emotion, isn't there?
I think the thing you mentioned earlier about one of the things we try and treat our kind of trainees is really important is, before you do something, think about what you're feeling, and then ask, is what I'm about to do to help this person in front of me, or is it to make me feel better?
Mm.
And that it really comes up with personality disorders, and that's really where sometimes you see unhelpful things happen, because I, as the doctor or the nurse, or whatever, with this person in front of me who's clearly stressed, feel really awkward and bad, and I feel terrible inside, and I want to make it go away. And I make it go away with one of two ways often: either to tell that they're just personality disorder, I won't see them, they're manipulative and terrible, take them away, which is, as I was saying, that kind of dismissing way of protecting yourself, or the over-caring, I'm going to do something now that's not helpful for them, but feels like it might be helpful. So maybe prescribing medication that I shouldn't do, because at least I'm doing something, and I'll feel like I'm doing something, and the person in front of me might feel like I'm doing something. And that's the real one. We have to just sit back and say, okay, what's useful here, not just what's going to make me feel better.
Yeah, thanks. That's I think there's probably a whole other webinar in that area alone, you know. But I think maybe that also might be a helpful question to ask as a partner or a family member, parent, you know, to kind of checking in with yourself as well. I'm just aware of the time kind of coming close to the end for now. I guess firstly, thank you all for joining and for all the questions. Hopefully we've gotten to the main bulk of them, and my apologies we can't answer specific queries. I would say again, as I mentioned at the beginning, if you're left with anything that's resonated, whether you recognize kind of parts of maybe your own challenges or maybe with someone else, I guess maybe it's around kind of seeking support and input around that. Well, what would you suggest if someone was kind of listening to this webinar and think, God, some of that does sound a bit close to home maybe, or kind of trying to unpack a bit, where might you kind of look for reputable information or support for yourself or for someone else?
So maybe if I just think a little bit about people who have difficulty with particularly suicidal thoughts, because that's very common, I would always recommend Pieta House and something called the Eden program, which is run by the charity Suicidal Survive, is actually very effective. It's quite an intensive intervention that I think addresses a lot of the kind of things we'd recommend in personality disorders. So having suicidal thoughts, that's quite a good area to think about. In terms of thinking about just general knowledge about personality disorders, there's quite a lot of stuff out there. The HSC has some information on its website. The College of Psychiatrists of Ireland would have a few things. We did something a couple of years ago for Borderline Personality Awareness Month that you can access from the College of Psychiatrists. Other charities like Mind, which is a UK mental health charity, and Mindwise, which is a Northern Irish one, they have some nice information leaflets on personality disorders, which I think are good to look at. I mentioned the Open Your Mind Before You Open Your Mouth. Remembered it. Family Connections information on YouTube. That can be very useful from a family member perspective. There's a nice podcast. They haven't made anything recently, but The Wrong Kind of Mad, which explores personality disorders from a relatively critical perspective, but it's quite an interesting perspective. So that's one that might be worth looking at. Also, if you're thinking about, well, I may or may not have a personality disorder, but I certainly have difficulties that I can identify with them. What could I do from a self-help perspective? There's actually quite a lot of self-help stuff out there. So things like DBT self-help, you can actually look at these things up and get a sense of some of the methods. So again, you can just Google those. They're quite, I always say to people, actually, DBT, probably anyone would probably benefit from DBT. It's just like a useful life skill. Actually, the aware life skills I think are actually also quite helpful. So, sometimes it's just about saying, well, I've seen a difficulty here. What can I go out there and look for some methods with? If you really feel like you have significant personality difficulties that might need more intensive treatment, then really getting a referral to your local mental health service would be the first step, because, as I said, diagnosis it's not a simple thing. There's quite a lot, you need to take these things into account on a kind of more longitudinal basis and look at lots of different bits of information. So that's where I would go if you have more significant difficulties.
Yeah, and that would be via the GP, wouldn't it? So that's some of the first protocol. Great, thank you, Paul. Yeah, I mean, it's been a really interesting conversation. Thank you so much for your time and your expertise. There's just so many things we didn't get to, so maybe we'll try to have you back again in different areas. But thanks so much for what you've shared today. I think just in closing, is there any one main takeaway that you kind of hope people listening or watching take away with them, or what's kind of the most important thing for you in terms of what we've been talking about?
So the most important thing for me, I think, is that personality disorders are common, treatable, and we really, really need to develop better services in Ireland for a really big group of need that is currently being missed.
Great. Okay, thank you so much, Paul. And
Thank
thank
you.
you all for joining us this afternoon. Moving on to the webinar for next month, so I'm delighted to be joined by Mark Freeston, who is a researcher in kind of types of thinking in depression, OCD, and generalized anxiety disorder. So do tune in if that's of interest. So thank you all for joining, and hopefully see you again next month.